Alright guys, so thanks for coming to this video. This video is going to be one of the first of many videos covering different topics in oral maxillofacial surgery. And in this video we're going to be covering wound healing, and it's the first video in this series. So the information in this video came from a few different places. It came from Peterson's Principles of Oral Maxillofacial Surgery, came from First Aid for the USMLE Step 1, and also OpenStack's Anatomy and Physiology, which is an open source book that actually was created by Rice University. So we might as well get into it. So the first thing we're going to talk about is regeneration versus repair. So regeneration, when we think about regeneration, we think about tissues that go back to their completely original functions. Structurally and functionally, they're completely the same as they were. And in contrast, repair is tissue with structure. Essentially, it's something where we have almost something that almost looks like the original, maybe macroscopically looks like the original tissue, but on a microscopic level, maybe it doesn't function, or structurally, it's not exactly the same. So when we think about that kind of stuff, we think about fibrotic change. So the only places where we really see true regeneration is the bone and the liver. But even the liver is questionable, because when you think about the liver, we should be thinking about portal triads, and that's kind of what's in the image here on the left-hand side. You'll see that we have the different, the artery, so the portal venule, the portal arterial, and the bile duct. The three usually travel together, and when we get regeneration of the liver, it usually doesn't have as clean and as concise of a format as the original structure of the different sinusoids and the different functional units of the liver. So we do get regeneration on a very technical level, but it doesn't usually look exactly the same. So, on to the next piece. So factors affecting healing. So there's a few different things that we really need to think about. The biggest one is cell activity. So when we think about cell activity, we think about its mitotic activity and its metabolic activity. So we think about its ability to essentially replicate, mitosis, splitting up into multiple cells. But we also need to think about its ability to lay down whatever it was laying down. So when we think about fibroblasts, we think about collagen. We think about osteoblasts, we think about bone. So we need to think about their ability to do what they were doing before when we think about cell activity. And we also need to think about their ability to actually replicate and to divide. Okay, so we have three different types of cell activities. We have labile cells, we have stable cells, and we have permanent cells. So labile cells are cells that replicate throughout the course of their entire life. And when we think about those kinds of cells, we think about epidermal cells, we think about oral mucosa, we might even think about the GI tract, some of those cells, because they're under constant abuse from the acid, right? Now, when we think about stable cells, we're thinking about cells that don't actively duplicate, but they can proliferate rapidly if it's in response to a stimulus. So when we think about something like that, we're thinking about something like mesenchyme. We're thinking about, when we think about mesenchyme, we're thinking about maybe bone cells, right? Because mesenchyme are it's the origin of osteoblasts and osteocytes, not of osteoclasts, but we'll get more into that later. But mesenchyme is one of the biggest things we think about, where it's stable, it's not really duplicating every day at a regular rate, the same way that you look at labile cells, like the intestinal cells. It's not the same, but when we look at stable cells, they can replicate if needed, okay? And then we think about permanent cells. And these are cells that generally don't have any division postnatally, okay? And we're thinking about cells of the nervous system, we're thinking about cardiac muscle. That's kind of what makes it so dangerous when people get an MI or something of that nature, because once you start getting fibrotic change of the wall, you risk things like free wall ruptures. And when you think about that, the fact that these cells can't regenerate, we can't regain the integrity of those structures, right? So on to the next piece, then we need to think about different types of healing, okay? So there's two main types of healing that we think about. We think about first intention healing, and we think about second intention healing. So if you're here already watching this video, you've probably taken the CBSE to get into oral maxillofacial surgery, or you're thinking about taking it, or you have at least some background. So you've heard of first intention and second intention healing. When we think of first intention healing, we think of something kind of small, something that's not too deep, and what really makes the difference between the two is how deep and how wide that wound is, okay? So first intention healing is when you have no wound dehiscence or scar formation, okay? Second intention healing is usually filling via granulation tissue and connective tissue, okay? And when you think of when we think about extractions, that is a specialized type of second intention healing, okay? And when we talk about healing for the next few PowerPoints, or next few, I guess you could say, presentations, we're going to be talking primarily about healing the skin, but we will get into more specialized healing of the bone and, yeah, I mean, pretty much of the bone is the biggest one because those are the two that we think a lot about. We will actually also talk about nervous system healing, okay, peripheral nerves. And so, second intention healing, we're thinking about the filling of granulation and connective tissue, and we should be thinking about things like avulsive injuries, infections, and adequate wound closure, okay? Those are bigger things. Those are things where, if you have a large infection, maybe of a wound that wasn't properly debrided, then realistically, that's probably it's festering and it's getting bigger and bigger and bigger, and you're not able to close it up with the mechanisms of first intention. So that brings us on now to third intention healing. And for third intention healing, we're thinking of complex wounds. So it's a combination of secondary healing with primary closure, and essentially it's secondary healing that's followed by primary closure. So you end up suturing after the wound has undergone debridement and has ample amount of time to heal by granulation. So you essentially have second intention healing, and you close it back up by primary closure afterwards, okay? So that would be third intention. So the healing continuum is made of 3 different phases, okay? We have the inflammatory phase, we have the proliferative phase, and the remodeling phase. So when we think about the inflammatory phase, we're thinking about a reparative response. It usually lasts about 3 to 5 days. Then when we think about the proliferative phase, we're thinking about adding granulation tissue. And the remodeling phase is essentially when we strengthen it. So when you're thinking about how the body works, there's an acute response that's just kind of to take care of everything right now. And then there's the proliferative, which is kind of like setting up scaffolding. But the remodeling is when you start to get a refined finished product. And you've probably heard a lot about collagen type 3, collagen type 1. When we think about which one's stronger, we know that collagen 1 is stronger, right? So in the proliferative phase, you see probably a much larger amount of collagen type 3 that eventually gets remodeled into collagen type 1. And that's through different cells like the macrophages and their metal metalloproteinases, etc. So looking at the phase 1 inflammatory phase, okay? So it's characterized by vasoconstriction, okay? We have cytokine-based clotting and platelet plug formation. So essentially, what we end up having is we have some tissue trauma, and we end up getting activation of factor 12, okay? And if we go forward, I'm going to move forward just for a second so we can look at factor 12, okay? If you look at factor 12 right here, it's part of the intrinsic pathway, okay? But factor 12 is really unique because we'll find that factor 12 is involved, in addition to converting fibrinogen to fibrin, it's actually also involved in breaking down that clot via plasmin. So we'll get to that. But that's kind of how that's kind of the start of the inflammatory phase. We see this activation of factor 12 to work on forming that clot. So the next thing is we have activation of complement systems, plasminogen, kinin, and clotting systems. So if you know that we have clotting systems and plasminogen, and if you think about it, when you think about clotting systems, that's essentially trying to create the clot, but plasminogen, we're thinking about getting rid of the clot. And that's because a lot of these things take time. So we need to start getting plasminogen ready for when the clotting system has done its job and we're ready to move from the inflammatory phase over to the proliferative phase. So now the next piece is we have platelets aggregating at the site of the injury. We have thrombus formation inside of a fibrin matrix. So if you've looked a little bit at all into the USMLE First Aid, you'll see they have a really nice graph where they show the platelets, they're binding to the von Willebrand factor, and the von Willebrand factor is actually also binding to the exposed subendothelial collagen. I'll fix that typo there. So like I said, we have the tissue trauma and local bleeding causing factor 12 activation. We also have neural stimulatory reflexes and endothelin from the damaged tissue causing vasoconstriction. And endothelin is one of many GQ agonists that increases inositol triphosphate, which is IP3 levels, and that increases the myosin light chain kinase activity, okay? And what that essentially does is it causes that vasoconstriction. That'll cause the vasoconstriction of all of the vessels that have a muscular shell around them. So moving forward, still in phase 1, the platelets start to degranulate and they're releasing, and among other things, they're releasing interleukins, TGF-beta, platelet-derived growth factor, that's PDGF, and vascular endothelial growth factor, which is VEGF. And once hemostasis is stable, you have vasoconstriction, and once all that's together, once it's stable, we have vasodilation, okay? And the idea then is that we're starting to get other mediators of healing into the wound site, okay? So we want histamine, prostaglandins, kinins, and leukotrienes, okay? And when you think about histamine responses, so we usually think about tumor, rubor, calor, dolor, okay? Now, I want to just talk really quickly about histamine responses and bradykinin, and I know they all don't really seem to have a tie-in together, but when we think about histamine, we think about vasodilation, right? And we have a lot of blood moving in. But another thing we think about also with vasodilation is bradykinin, right? Bradykinin, in fact, if I remember correctly, if you have a C1 esterase inhibitor deficiency, then you are at risk of angioedema, big time, especially if you're taking something like an ACE inhibitor, right? That's actually one of the biggest contraindications for taking an ACE inhibitor. So, and where does that all come together? Well, the important thing to note is that high molecular weight kininogen should make us think of 3 things. The first thing is that it stimulates activation of factor 12, because which causes fibrinogen to become fibrin, okay? And the high molecular weight kininogen ends up becoming bradykinin, which also causes vasodilation and permeability. And lastly, kallikrein actually ends up activating plasminogen to create plasmin, which starts cutting up the clot once the clot begins to stabilize, and vasodilation/perfusion is needed to facilitate the healing. So if we look here, what we'll see is that we have factor 12, this is kind of what I was touching on a little earlier, we have factor 12 getting activated, and that is directly involved with fibrinogen being converted into fibrin, okay? But we also see that factor 12, if you read on the left-hand side, right left of plasmin there, we see factor 12, among other things, is actually activating plasminogen to plasmin. So it's almost self-limiting, and we see that everywhere in the body. We see it's almost like a negative feedback loop. And it's not negative feedback in the sense that, it's not negative feedback the way that, maybe TSH and T3 are negative feedback. I mean, in that sense, it's very linear. It's like it's linearly feedbacking. In this sense, though, we have one thing that's splitting up and doing 2 functions at the same time, and one is getting ready for the end of the other. And this just kind of highlights that further. So this graph here should be, or this chart, or this figure, should be really familiar to you if you've looked at the first aid USMLE, the heme section. So you'll note that we have the intrinsic pathway there, and at the very top right there is factor 12. And so factor 12, if you follow it down, is involved in converting fibrinogen, factor 1, to fibrin monomers, which is factor 1A. But what's not shown here is that, it's not shown on this specific chart, but we saw it somewhere else, was that factor 12 is involved in also activating the plasmin, which gets us ready for the next part, where we need vessels to actually let blood in, so that all the things we need, from inflammatory mediators to inflammatory cells, everything we need to move on to the next phase of healing is there and ready to go. So, carrying on with that, the next big thing we need is increasing vascular permeability. We need that so that plasma, cells, and cytokines can all pass through via diapedesis, right? And this manifests often as just what we talked about earlier, swelling, tumor, okay? And I remember that tumor is swelling because of tumors, right? Swelling. And then we have rubor, which is the redness, okay? So we think of rubies, so rubor, rubies, right? Then we have pain, which is dolor, and I mean, that's the only one that doesn't have a great one. And dolor is actually an English word too. It's used to mean sorrow or sadness. I mean, if you already know that word, you already know that word. But the last one is heat, which is calor, okay, or calories. And if you think about, actually, something that I thought was really interesting in a way that I personally remember it, is that they measure calories essentially by seeing how many, it's something along the lines of how many grams of water or how much heat it takes to, or you know what it is, it's how many degrees hotter each gram of water can go by burning the item of food that you're measuring how many calories it is. So that's how calories are measured. That's its original origin. So the actual measurement of calories used to come from heating up or burning food, trying to see the change in water temperature. So that's where the word calories comes from. That'll help you remember that heat is calor. Okay. And so next up is cytokines chemotactically attracting neutrophils and monocytes. So neutrophils occur within minutes, and so we usually think about neutrophils as being kind of the acute mediators, right? And they release their proteases and their cytokines. So the proteases and cytokines from the neutrophils, they help tackle the bacteria and degrading the matrix components and devitalized tissue. Usually neutrophils are gone within a couple of days, but the TNF-alpha, IL-1, and IL-2 that they secrete all stay around, promoting inflammation for extended amounts of time. So this is just to kind of show us a little bit about, right here, we have neutrophils coming up first, okay? And then from there, we also have macrophages coming in right as the neutrophils are starting to leave, okay? And then, of course, you have in this, right here, we have the different cytokines and, you know, things that they release. So, activated monocytes in the given situation are called macrophages. And we'll find that monocytes have different names depending on where we are. They release collagenases and elastases to help clean up injured tissue and phagocytose bacteria. The primary mediators of healing that they release are everything you see listed below: TGF-alpha, TGF-beta-1, PDGF, IGF-1 and 2, TNF-alpha, and IL-1. Okay, but I thought this was a really nice picture, and it kind of talks about the different functions of, essentially, of the macrophage in the wound healing. So it promotes the wound closure, right? Re-epithelialization and contraction, expresses growth factors, helps with wound cleansing and debridement. It promotes the healing and it assists in the resolution of wound inflammation. So a little more information on there if you want. But the point is that it regulates more than cleanup, right? It regulates proteolytic enzymes. Like we talked about earlier, we have matrix metalloproteases. And one of the biggest things is that when the macrophages are gone, the things that they release are actually still helping. So they regulate a lot of these processes even once they've been removed. Their matrix metalloproteases are actually what's responsible for the conversion of collagen type 3 to collagen type 1. And so what their effects are they are one of the biggest mediators of the healing process even after they're gone. They induce the ECM formation, this extracellular matrix. It regulates angiogenesis and fibroplasia. And like I said, their presence and effects are usually minimal by day 5 of healing, but the modulation that they have on the above processes, they all go on until healing is usually complete. And healing, if we think about the third phase of healing, the third phase is the remodeling phase. That can take years, okay? So now we're going to move on to the second phase, though. The second phase is the proliferative phase. So the proliferative phase can generally start by the third day after injury, and it lasts for weeks. And the flagship finding that we think about is granulation tissue, okay? And that's fibroblasts, angiogenesis, inflammatory cells. And I thought this picture was really good, okay? So it kind of shows you the different phases or different pieces of the healing process. Oh yeah, okay. So looking at it, so the angiogenesis that we end up seeing inside the proliferative phase, it helps getting the area well perfused to promote healing, okay? And we'll talk a little later on about hemostasis in wound closure. And hemostasis is 100% important. We need to make sure that wounds are not just sopping in blood, but at the same time, if we make them, if we completely tie off any chance of blood supply that they would have had, we actually risk not giving it enough perfusion to help it heal. Okay, and perfusion is critical because a lot of the mediators of healing are coming from outside sources via the blood. So the actual angiogenesis, it's stimulated by VEGF, okay, and FGF2 and other cytokines. So fibroblasts are chemotactically migrating from a lot of the things that are being released inside of the wound during the first phase, the inflammatory phase, right? And when they get there, they're starting to help form the ECM formation, and they're the ones that are secreting that initial type 3 collagen, okay? So one thing that's a really interesting clinical note is if you can, try to think for a second, pause and think, what is one time or one condition you can think of that has an issue with type 3 collagen? And what effect might this have on the healing process? Let you pause there and you can think about it. And if you pause, we can just pick up right here. So one example of something that could cause problems there is actually the vascular type of Ehlers-Danlos syndrome. So that is essentially causing an issue or a deficiency of well-functioning type 3 collagen. So you can imagine fibroblasts are having a hard time depositing it, and even later on, we might have some issues with the remodeling of it from type 3 to type 1 because we're having issues forming it to begin with. So now, we're going to talk about essentially the myofibroblasts, okay? So wound contraction begins to start via the myofibroblasts, and essentially we have activated fibroblasts. They're continuing to stimulate themselves all throughout this process. And one thing we need to think about actually is things that could delay it based on this patient. So if we think about patients that could be deficient in copper and vitamin C, I mean, we think about vitamin C deficiency, we think scurvy, right? But scurvy is obviously not something that I think when I hear scurvy, I think of like pirates back in the day, the ones that were on the ship for days and days and days, and they didn't have access to fresh fruits or anything like that. But there's actually a really important group of people, there's a demographic that this really speaks to, and that's the elderly. So a lot of the elderly, especially widowers, actually, we find that widowers are some of the most they have some of the worst malnutrition. And that's actually not news, that's a fact. And it would not be too shocking to see that it manifests as something like a vitamin C deficiency. So we need to think about that when it comes to delays in the healing process, because in this figure on the right here, this also is from the first aid. You see that vitamin C is required for the hydroxylation of proline and lysine. So that's just one really important way where vitamin C is crucial, actually, to the healing process. So let's move on forward. So now, epithelial growth with epidermal cells from the margins of the wound, it starts to proliferate on over, okay? And once the two edges meet, the growth stops, okay? So on skin, the epithelial cells migrate under the scab of the dermis. We have the scab up top, and that's kind of what you and I see. But underneath, we have the epithelial cells slowly moving towards each other. But in the oral cavity, the epithelial cells are actually migrating directly onto the mucosal surface, okay? And so I just kind of pulled up an image here on the right-hand side, or a little diagram. And you'll note, one thing that's important to note here is that the wound begins to resurface above the basement membrane, okay? And so the basement membrane is what separates the epidermis from the dermis. So in here, we can actually see the dermis right here, right? Okay, and we have the epidermis, all of this. So right above there is where we actually have that re-epithelialization, okay? And we see much quicker re-epithelialization in the oral cavity than in skin. So when the two sides meet each other, I shouldn't even say two sides, because this is not a two-dimensional wound, it's a three-dimensional wound. So when the margins start to meet each other, once they meet each other and stop, that's contact inhibition. And contact inhibition isn't new to us. We actually see contact inhibition even in bacteria, right? That's why bacteria doesn't just grow over the edge of a petri dish. Once it reaches the ends, it kind of stops off. It's really interesting. They actually use that now. They manipulate that feature to try to create what they call bacterial. They essentially try to replicate computing processes using bacteria, and they can scale bacteria to any size they want without fear of it overgrowing because of contact inhibition. So contact inhibition, essentially, it's our way of knowing, it's time to end. In a bacteria, we have, that inhibition is mediated by something called quorum sensing, but when it comes to the skin, I'm sure there's something very similar. Okay? So when the edges meet, the wound starts to contract via the myofibroblasts, okay? And factors affecting the contraction itself, essentially how deep you end up getting that contraction, The width affects it, the depth affects it, the location affects it, okay? And this was just a nice little picture I found. This is the third image of the previous set of 3 images in the PowerPoint, okay? And sometimes the force of contraction can be strong enough to even affect osseous structures. So the last piece here is we're going to talk about the remodeling phase. So the remodeling phase can be several years long, and it's characterized by strengthening and maturation of the scar tissue. But one of the most important things here to remember is that collagen type 3 is being converted to collagen type 1. And there's a lot of implications in that when we think about those patients with Ehlers-Danlos, the vascular type. And that process is actually mediated by those metal metalloproteinases, so matrix metalloproteinases, MMPs, that we found from the macrophages. So a couple points here. So the metabolic demands of the healing process start to go down, and so the network of capillaries from the wound induced angiogenesis starts to pull back. Okay, and up to 80% of the original tensile strength returns into the wound. But much of the ECM maintenance, the extracellular matrix maintenance, and collagen conversion is regulated by serine proteases and matrix metalloproteases, and that is evidence of the macrophage's influence much later on in the game. And the regulation of all this activity is what prevents scar from going to either ends of the wound healing spectrum. We could have dehiscence on one side and large scar formation on the other side. We could even have hypertrophic scars. We could have keloids. Those are both things we're going to talk about in an upcoming lecture. But that just about wraps up this lecture, and I'll see you in the next one where we'll talk a little bit more about wound healing.